Hello, dear respected students. Today we will talk about two topics: respiratory failure and cor pulmonale. Respiratory failure is a pathological syndrome in which the respiratory system is not able to fully perform its function under normal operating conditions to provide a normal arterial blood gas composition. That's why arterial blood gas analysis is the gold standard for assessing pulmonary failure. Here are some parameters of arterial blood gases. For example, oxygen pressure should be between the 80 to 100 mmHg, whereas CO2 should be between 35 and 45 mmHg. And very important parameter is O2 saturation, which should be more than 95%. Pathological syndrome, respiratory failure is pathological syndrome in which the partial pressure of oxygen in the arterial blood is less than 60 mmHg and partial pressure of carbon dioxide is more than 45. When decreased level of O2, we call this hypoxia condition. When CO2 is more than 45, we call this hypercapnia condition. There are several groups of causes of respiratory failure. First group is pathology of upper respiratory tract. Difficulty breathing can be caused by a neoplasm of upper respiratory tract, pathological formation, for example, aortic aneurysm adjacent to the trachea, cicatrical changes, developmental anomalies, aspiration of foreign body. And true and false group of infectious genesis are most relevant in children of younger age groups. Also, expiratory tracheal stenosis is a rare pathology that is caused by atony of smooth muscle of posterior wall of trachea. The posterior wall devoid of a cartilaginous base becomes very pliable, and on exhalation it can significantly sag and block the tracheal lumen, a viral etiology suggested. Obstructive sleep apnea syndrome is another syndrome, is a pathological syndrome characterized by the development of respiratory arrest during sleep lasting more than 10 seconds with a frequency of more than 10 per hour. In this case, there is an overlap of airflow at the level of upper respiratory tract anatomical defect, as a result of which the inhaled air, despite the excursion of the chest and abdomen, does not reach the lungs. Clinically appears by nocturnal snoring interrupted by episodes of respiratory arrest, daytime sleepiness, arterial hypertension, especially in the morning hours, and cardiac arrhythmias. There are predisposing factors like obesity and alcohol consumption. Second group is pathology of chest and diaphragm. For example, kyphoscoliosis is a lateral curvature of spine with posterior rotation of ribs, or pathological kyphosis or hump. The cause is often pathological fractures of spine, a complication of steroid hormone therapy, or tuberculosis spondylitis. Bilateral diaphragm paralysis of the spinal cord injury, polymyelitis, polyneuropathies, bilateral involvement of phrenic nerves in the pathological process in the presence of mediastinal masses. Another reason is paralysis of intercostal muscles. Does not in itself cause severe respiratory failure, but sharply aggravates it in combination with the pathology of the diaphragm. Next is very important. Pickwick syndrome is a combination of severe obesity with extreme drowsiness, pathological increased appetite, severe pulmonary and heart failure. A rapid development of severe polycythemia and right ventricular heart failure is characteristic. Excessive accumulation of adipose tissue in the abdominal cavity leads to a limitation of mobility of the diaphragm and accordingly hypoventilation. An important role belongs to the increase in energy requirements due to excess fatty tissue. Next group is disease of lung and pleura. all diseases of the lungs sooner or later leads to violation of their function, leads to respiratory failure. For example, repeated pneumonia, COPD, bronchial asthma, sarcoidosis, any disorders can result in respiratory failure. Next is pathology of respiratory center. Damage of respiratory center with the development of hypoventilation can be caused by inflammation, traumas, hemorrhages, neoplasm. One of the common causes of hypoventilation is inhibition of respiratory center of medication origin, for example, anesthetics, barbiturates, morphines, and etc. Central sleep apnea, another syndrome, is a pathological condition caused by the appearance of episodes of lack of breathing lasting more than 10 seconds with a frequency of more than 10 per hour due to the temporary absence of an impulse from the central nervous system to activate the respiratory muscles. It occurs in persons with disorders of central mechanisms of respiration regulation, is associated with deep, often anatomical damage to the nervous system. Mixed sleep apnea, central and obstructive, is common. And another very important and interesting syndrome is Undine-Kurz syndrome, more appropriately known as congenital central hypoventilation syndrome, is a rare severe form of sleep apnea in which an individual completely stop breathing when falling asleep. It's always congenital, meaning that it's present from birth. Disease affects only boys. Etiology of disease is a gene defect. In 1932, two scientists described the cause of Undine syndrome, a rare form of central sleep apnea. They observed the patient with severe damage to pathways of brain who lost automatic control of ventilation and retained only voluntary control, and patient could breathe only when he was awake. While failing asleep, he developed apnea. There are two types of respiratory failure, acute and chronic. Acute respiratory failure develops within a few days, hours, or even minutes and requires intensive therapy. For example, acute asthma attack, bronchial asthma attack, or pneumothorax, as it can pose an immediate threat to the patient's life with the rapid development of respiratory failure. Compensatory mechanisms from the respiratory systems, blood circulation, acid-base state do not have time to turn on. And chronic respiratory failure, for example, in COPD or sarcoidosis, TBS, develops over months to years. The onset may be subtle and gradual. On the mechanisms of development, we recognize three types: restrictive, mixed, and obstructive type. Restrictive respiratory failure is characterized by a decrease in the vital capacity of the lung. For example, lung consolidation syndrome, or fluid in the pleural cavity, or chest deformity and diaphragm paralysis. Obstructive respiratory failure and difficulty in the passage of air through the respiratory tract, for example, develop due to bronchial obstruction syndrome. Mixed respiratory failure is a combination of obstruction and restriction syndromes with a decrease in vital capacity, for example, inflammatory bronchial edema with hypersecretion and pulmonary emphysema syndrome. There are symptoms of respiratory insufficiency. A specific symptom of respiratory failure is shortness of breath or dyspnea, which may be expiratory, inspiratory, or mixed. From history or anamnesis, you can find out indication of chronic bronchial pulmonary disorders, and during examination, you can find respiratory rate is more than 20 per minute, and changing of depth of breathing, and also you can find out a very specific symptom of respiratory failure is warm central cyanosis. There are 3 degrees of respiratory failure according to clinical appearance and gas containing. For example, we have three grades: mild, moderate, and severe respiratory failure. In mild respiratory failure, we have no dyspnea at rest, but in very severe loading, physical loading, we have the dyspnea appear, and in severe cases we have dyspnea even at rest. And also according to phrase, building, breathing rate, cyanosis, presenting, pulse rate, different stages has different appearing, and saturation of hemoglobin, saturation of oxygen, if in normal condition should be more than 95, in severe condition it will be below 60. The gold standard and key methods for diagnosis pulmonary insufficiency is the study of gas and acid-base composition of arterial blood. Blood oxygen saturation can be measured invasively and non-invasively. Invasively by examining arterial blood using special devices, and non-invasively using a pulse oximeter. You see here pulse oximeter, the sensor of device photocell is applied to the finger, earlobe, or nose. Advantages: unlimited number of measurements in any conditions, and long-term monitoring of oxygenation of patient. And disadvantages: it evaluates only one parameter and it's not always accurate. Next, our syndrome is cor pulmonale. What is cor pulmonale? Pathological condition characterized by hypertrophy and or dilation of the right ventricle of the heart due to the arterial pulmonary hypertension with lesion of the respiratory system. There are three categories of etiology factors. First is damaging of bronchial pulmonary apparatus. There are very different disorders which include the bronchitis pathology and pathology of pleura and even lungs. All disorders, chronic obstructive bronchitis, pulmonary emphysema, fibrosis, for example, pneumoconiosis, sarcoidosis, and etc. Next very large group is damage of thoracodiaphragmatic apparatus, for example, kyphoscoliosis, pathology, Pickwick syndrome, pathology of diaphragm, and etc. And last is damage of pulmonary vessels, vasculitis, primary pulmonary hypertension, pulmonary embolism, and etc. And of course, very important point, nota bene, to put diagnosis of cor pulmonale, you should exclude pathology of left half of heart. To understand pulmonary hypertension in cor pulmonale, you have to know normal pressure, in heart chambers and in main vessels, and of course you should exactly know pulmonary artery pressure. Systolic pressure should be not more than 30 mmHg, whereas diastolic pressure not more than 15, and it's very important, average pressure is 17 to 23 mmHg. Average pressure should be not more than 25 mmHg. And let's discuss about cor pulmonale pathogenesis or pulmonary heart pathogenesis. Cor pulmonale pathogenesis, which called because of hypoxia, decreased blood oxygen saturation. First, main important, and due to three etiological factors, for example, etiological factors of cor pulmonale, all of them can result in alveolar hypoxia, decrease O2 in alveoli. which cause the activation of Ehlers-Danlos reflexes, which was discovered in 1946, and also narrowing of lumen of pulmonary arteries as a result of thrombosis and embolism. They call the reducing of cross-section of vessels of the lungs, which result in increasing total pulmonary vascular resistance. And if increased total pulmonary vascular resistance increase pressure in pulmonary artery, which cause the overload of right heart. Right heart have to work to the high pressure, and right heart become to be right heart compensated by his hyperfunction, and prolonged time hyperfunction can result in hypertrophy and day by day develop dilation of right heart and right ventricular failure, and of course death. Also, we should distinguish another pathology of left heart chambers, which also result in pulmonary arterial hypertension, but this pulmonary arterial hypertension we not call as a cor pulmonale. This is different. We should distinguish this left heart chambers pathology. How develop pulmonary arterial hypertension in left heart failure? For example, in left heart failure or left side heart failure, or for example mitral stenosis or mitral regurgitation condition, we have increasing pressure in left atriums, and which cause the activation of Kitaev reflexes, spasm of pulmonary arteries as a response to increasing pressure in left atrium. This causes a reducing of cross-section of vessels of lungs and increasing total pulmonary vascular resistance with increasing of pulmonary pressure, and also cause the hypertrophy and dilation of right heart and right ventricular failure. Pulmonary arterial hypertension due to pathological increase in resistance to blood flow with hypertension of pulmonary arterioles. We have two types, primary and secondary. Primary with pathology, primary pulmonary hypertension. Secondary is in response to alveolar hypoxia, for example, alveolar ventilation disorders, kyphoscoliosis, and bronchial asthma, etc. And second mechanism due to the anatomical decrease in lumen of arterial pulmonary bed due to sclerosis, obliteration, for example, in areas of neurosclerosis, pulmonary fibrosis with vasculitis, and thromboemboli of pulmonary arteries. And cor pulmonale divided into acute, subacute, and chronic types. Acute cor pulmonale develops in a few hours or days with massive thromboembolism of the pulmonary arteries, valvular pneumothorax. Subacute develops in weeks and months with repeated thromboembolism of pulmonary arteries, primary pulmonary hypertension, lymphogenous carcinomatosis of lungs, severe bronchial asthma or bronchiolitis, and chronic formed against the background of long-term respiratory failure. According to development stages of cor pulmonale, we have preclinical, before the clinical. Here is transient pulmonary hypertension, the sign of right ventricular hyperfunction, can be detected only by instrumental research, and right ventricular hypertrophy stage and stable pulmonary hypertension. Right ventricular hypertrophy stage, we call it, another name is compensatory phase, and in this phase no circulatory failure, no right ventricular failure, and decompensated cor pulmonale when developed right ventricular heart failure. Clinically, acute cor pulmonale appear by small cardiac output syndrome with clinical manifestations of collapses and retrograde conditions in the veins of systemic circulation. Why develop small cardiac output syndrome? A small cardiac output syndrome developed because our our right ventricle has to has to pump against the high pressure and couldn't pump entire blood into the pulmonary circulation. We have less blood in pulmonary circulation, less blood comes to the left side and less blood go to the systemic circulation, and the more pressure in pulmonary artery we have, the less cardiac output. Chronic cor pulmonale, the stage of compensation, is recognized by the symptom of hyperfunction and right ventricular hypertrophy, only right ventricular hypertrophy. To put the diagnosis of compensatory stage, you could find only right ventricular hypertrophy, for example, by palpation, percussion, also by ECG and echocardiography. In the stage of decompensation, develop right ventricular failure. Clinically, pulmonary arterial hypertension manifested by retrosternal pain due to stretching of pulmonary artery trunk and increasing pulmonary artery pressure. Also, you could find by palpation pulsation in second intercostal space on the left side. This is because of enlarging of pulmonary artery, and accent and splitting of S2 over pulmonary artery, dizziness, fainting, and respiratory rhythm disturbances. Symptom of right ventricular hypertrophy, this is cardiac impulse at fourth intercostal space at the left edge of sternum, epigastric pulsation, and expansion of border of heart to the right during percussion. Right ventricular heart failure syndrome, when developed decompensatory phase, it may appear by palpitation, dilated neck veins, a weakening of S1 and systolic murmur at the xiphoid process, and Graham-Still diastolic murmur, relative tricuspid valve insufficiency, rhythm disturbances, and increasing size of liver, hepatomegaly develop, ascites, swelling in the lower limbs, lower back, abdomen, and oliguria. Diagnostic methods, there are chest X-ray, CT, MRI, ECG, echocardiography, radionuclide ventriculographies, and gold standard for the diagnosis of pulmonary arterial hypertension is catheterization of right heart chambers with measurement of pulmonary artery occlusion pressure. Pulmonary occlusion pressure, also known as pulmonary capillary wedge pressure, provides an indirect estimate of left atrial pressure. Also, left ventricular pressure can be directly measured by placing a catheter within the left ventricle. You see there are some differences between the pulmonary arterial hypertension in cor pulmonale. Cor pulmonale is developed because of only pulmonary disorders, and also pulmonary hypertension can develop due to the left heart disease. What the differences between these two situations? In both of them, in pulmonary hypertension, which caused by cor pulmonale and left heart disorders, we have increasing mean pressure, mean pulmonary arterial pressure more than 25 in both of them, but in cor pulmonale we have and you see pulmonary occlusion pressure less than 15, because in left atrium normal pressure, there is normal pressure. In left heart disease we have increasing pressure in left atrium. That's why we have here we have increasing pressure, increasing wedge pressure, pulmonary wedge pressure more than 15. X-ray. In X-ray, you see signs of underlying disease, increasing diameter of right branch of pulmonary artery, bulging of pulmonary cone, and pronounced vascular pulsation, depletion of pulmonary patterns of periphery, enlargement of the right heart. And ECG, there are signs of left ventricular right atrium hypertrophy and right ventricular hypertrophy. Here will be right atrium hypertrophy and right ventricular hypertrophy signs. And echocardiography, increased pressure in the pulmonary artery, average is more than 25, increased right ventricular wall thickness, increase in anterior septal size of right ventricles, paradoxical movement of interventricular septum, early closure of pulmonary valves, and incomplete closure of tricuspid valve. And you see here dilation of right side of heart, the paradoxical movement of interventricular septum and interatrial septum, and right ventricular hypertrophy and dilation. The wall thickness exceeds the wall thickness of the left ventricle. I finished my lecture. Thank you for your attentions.